Hello everyone, welcome to my clinical discussion on carcinoma of breast. I don't want to waste your valuable time discuss a demo case here. Rather, I will discuss some important clinical topics with you. So let's proceed. Types of breast cancer. It is divided by stromal origin and epithelial origin. Stromal origin tumors are fibroadenoma, lipoma, hemangioma, phylloid tumor, and sarcoma are the most common. And epithelial origin, there is papilloma and carcinoma in situ. The example of carcinoma in situ are ductal carcinoma in situ and lobular carcinoma in situ and invasive carcinoma. Sometimes it is asked that breast cancer can occur in case of male. Answer is yes, it can occur. But the gynecomastia is not the risk factor for the cancer. Risk factors are the more prone to have a breast cancer in case of male when there is Klinefelter syndrome occurs, and in old age BRCA mutation occurs commonly, which is also risk factor for the male breast cancer. And male breast cancer is always associated with estrogen receptor status positive. That means they are very good prognosis and response well to the hormone replacement therapy and as well as chemotherapy. What are the painful lump in the breast? Mastitis, fibroadenosis, breast abscess, traumatic breast necrosis. And what are the example of painless lump in the breast cancer? At first, we need to tell about carcinoma breast, then phylloids and fibroadenoma. Risk factors for breast cancer. Some are modifiable risk factors and some are non-modifiable risk factors. Modifiable risk factors are obesity, nulliparity, age after marriage after 35 years of old. Breastfeeding is a protective practice, and age at first childbirth, use of hormone replacement therapy, tobacco, alcohol, and radiation exposure are the risk factor. And non-modifiable risk factors are increasing age, sex. In case of female, it is more prone to have breast cancer. Ethnicity, family history, which we'll discuss later, genetic predisposition, early menarche, less than 12 years old, late menopause, more than 55 years of old, because it means the more duration of exposure of estrogen to their reproductive life, and high risk of breast lesion. So what is the importance of family history? In case of breast cancer, 70% are sporadic. That means which is not associated with family history. About 25% is family breast cancer history is positive. Then genetic and hereditary breast cancer, BRCA1 mutation, BRCA2 mutation, P53 alpha gene mutation, which is termed as Lee-Fraumeni syndrome, Cowden disease, Peutz-Jeghers syndrome, and Moore-Torrey syndromes are the hereditary breast cancer causes. Let's discuss something about BRCA1 mutation and BRCA2 mutation. BRCA1 mutation occurs at the chromosome number 17q, and in case of BRCA1 mutation, the carcinoma is estrogen receptor, progesterone receptor, and human epithelial growth factor receptor 2 status is negative. That means it is the worst prognosis and not response to the hormonal replacement therapy and as well as chemotherapy. About 80% of the patient develop breast cancer and 20% of the patient develop ovarian cancer in case of BRCA1 mutation. BRCA2 mutation occurs at the chromosome number 13q, and here estrogen receptor and progesterone receptor are the positive, so prognosis is good. And about 60% patient develop breast cancer and 20% of them develop ovarian cancer. And BRCA2 mutation is also associated with male breast cancer as well as prostate cancer, colon cancer, gastric cancer. One thing I would like to mention that hormone replacement therapy is risk factor for postmenopausal women only, but a young woman less than 25 years old having bilateral salpingo-oophorectomy she needs obviously hormonal replacement therapy, but that is not a risk factor for her. Here we have discussed that use of hormonal replacement therapy is a risk factor, but it is risk factor for only the postmenopausal woman, not a young woman whose age is less than 25 years of old. Okay, then discuss the spread of breast cancer. How breast cancer spread into the different parts of our body. It can be spread locally. It involves skin and penetrate pectoralis muscle, which is pectoralis major muscle, and pectoralis minor muscle covered by pectoralis fascia. And so when breast cancer is involved with the skin or the penetrate the underlying muscle, we termed it as a locally advanced breast carcinoma. Then lymphatic metastasis. Primarily axillary lymph nodes and internal mammary lymph nodes are affected, and in the late phase supraclavicular nodes and contralateral lymph nodes are affected. Spread by bloodstream. Skeletal metastasis occurs mainly in the lumbar vertebra via Bateson plexus. Femur, thoracic vertebra, rib and skull are also affected. Visceral metastasis, brain are the most common site, then liver, lungs, adrenal glands and ovaries. Here is a term used to describe multifocal and multicentric lesion. What is multifocal and what is multicentric? Okay, when the lump are present in one quadrant of the breast, it is termed as multifocal. We know we can divide breast into four segments: upper outer, upper inner, lower outer, lower inner. And when multiple lumps are present more than two quadrants, it is termed as multicentric. Now name a carcinoma which is at the same time multifocal and multicentric. That is lobular carcinoma. 10% like multifocal, multicentric, and it is bilateral. So now we'll discuss about the molecular classification of the breast. Molecular classification, we need to know about the status of hormone. If a patient is estrogen receptor is positive, that means it is the carcinoma is good prognosis. But when estrogen receptor of the lump is negative, then the carcinoma is at bad prognosis. But human epidermal growth factor receptor 2 becomes positive, it means a bad prognosis. So we need to remember that when it become positive, it means bad prognosis. Okay. So what are the molecular classification of the breast carcinoma? Luminal A carcinoma, luminal B carcinoma, basal carcinoma, and human epithelial receptor growth factor 2 enriched breast carcinoma. In case of luminal A breast cancer, there is estrogen receptor is positive, progesterone receptor status is positive, human epidermal receptor growth factor status is negative, and Ki67 index is low. What does it mean, Ki67 index? It means the multiplication index. Okay, so multiplication index is low and its prognosis is very good. In case of luminal B, estrogen receptor status positive, progesterone receptor status is also positive, and human epidermal growth factor receptor status can be both positive or negative, and Ki67 index is high. And in case of basal carcinoma of breast, estrogen receptor is negative, progesterone receptor is negative, and human epidermal growth factor receptor is also negative. So it is termed as triple negative. And Ki67 index is high. So it is the worst prognosis. Okay. And what is about human epidermal growth factor receptor 2 enriched? It is estrogen receptor negative, progesterone receptor negative, and human epidermal receptor growth factor is positive, and Ki67 index is high. So it is worst prognosis and it is bad prognosis. So basal carcinoma of breast is bad prognosis, and human epidermal receptor growth factor enriched tumor is worst prognosis. Investigation, we need to concern about triple assessment. What is triple assessment? Triple assessment is a combination of investigation which includes clinical examination, imaging, and pathological examination. In case of clinical examination, we need to know about age, because breast carcinoma is highly associated with age, because of we need to take history from the patient about her pregnancy, about her periods, everything, and also breast examination, which includes inspection and palpation of the breast. Then imaging, we need to do ultrasonogram and mammography. We will discuss it later. And pathological examination, we gold standard pathological examination is core cut biopsy or true cut biopsy, but we also perform fine needle aspiration cytology or FNAC, and it confirm diagnosis in 95% cases. Investigations are divided into three regions. One is radiological investigation, which is ultrasonography and mammography. Pathological investigations are FNAC, fine needle aspiration cytology, core needle biopsy, which is true cut biopsy, and sometimes open biopsy, means incisional and excisional biopsy. When we'll take incisional biopsy, when there is an ulcer, and when we'll take excisional biopsy, when the tumor size is less than 4 centimeter, and we will take less than 4 centimeter, and we'll take 1 centimeter healthy tissue and totally cut up the tumor to examine the small size of the tumor or lump. Then we need to do excisional biopsy, and when there is a ulcer, then we need incisional biopsy. Okay, and when the lump is multicentric or multifocal and size is like large in size, then we perform true cut biopsy. For staging purpose, we need to do X-ray, abdominal ultrasound, CT scan, and CT scan of brain for find out metastasis. So let's discuss about mammography. What possible characteristics we can find out from a mammography? Architectural distortion of breast tissue. Okay. Then duct dilatation. Look at, there is duct dilatation. Okay. Then dense stellate soft tissue mass with irregular margin and spiky projection. Microcalcification in elderly patient. Stipple calcification is characteristics, increased thickness of the skin. Look at the skin, increase the thickness of the skin, and nipple retraction may be seen. Look, here is nipple is retracted. Okay, nipple is retracted from lateral and inferior portion. Okay, in inspection we'll find some skin abnormality. One of them is Paget's disease of the nipple. What is Paget's disease? Paget's disease is a unique type of ductal carcinoma in situ arising in the nipple. It presents as erosion of the nipple that slowly destroy the nipple and encroach on the areola. Okay, it destroy areola and the nipple portion. It may become invasive with metastasis to the axillary lymph node, and triple assessment is needed to exclude underlying malignancy. Here I want to elaborate the second point, why it is called that it is said that metastasis to the axillary lymph nodes, because when there is a skin involvement, it is termed as locally advanced carcinoma of breast, and in case of locally advanced carcinoma of breast, there must be axillary lymph node will be affected. Okay, so what will be the treatment? There is a two condition: Paget's without associated underlying malignancy. So we need core excision, removing a cone of major milk duct with nipple areola down to the pectoralis major muscle, followed by radiotherapy. And if Paget's present with malignancy, then mastectomy and evaluation of the axillary nodal status. Okay. Then next skin abnormalities are purity orange. What is purity orange? With growth of tumor, the tumor cells involved block the subdermal lymphatic, and this causes cutaneous lymphatic edema. So in case of cutaneous lymphatic edema, the skin area tethered to sweat ducts cannot swell, remain dimple in the between of the areas of cutaneous lymphatic edema, giving an appearance of orange. It means there is a ligament of Cooper's. Okay, the some region, the ligament of Cooper's are attached to the skin. Okay, and in between them there is a no attachment of ligament of Cooper's. So where the ligament is attached to the skin, it may dimpled. Look here, it is dimpled or tethered at the skin, but another or surrounding region are edematous or lymphatic edema is present. So it is look like a orange. Okay, in Bayesian love there is a term is used when the PD orange is present more than 2/3 of the area, it is classified as T4D. And when in a limited area, like suppose in such of this area or this area, it is a limited area, then it is classified as T4B. Okay, so limited area T4B and more than 2/3 T4D, as D comes after D. So D is a D is used for diffuse area. Okay, like remember like this, D is used for diffuse area more than 2/3, and B is like a specific region. So we should go to the next slide, which is staging system. It's very much important. Please read TNM staging for written. I will discuss Manchester staging. So we divide stage 1, stage 2, 3A, 3B, and stage 4 breast cancer. When we'll tell stage 1 breast cancer, when the tumor size is less than 2 cm in diameter. Then stage 2 breast cancer is termed as when tumor size is 2 to 5 cm with or without ipsilateral, palpable, and the main important clue is here, mobile axillary lymph node. Axillary lymph node should be palpable, but it will be mobile. When the axillary lymph node is fixed, it will go stage 3A breast cancer. Stage 3B breast cancer is termed when there is skin involvement, there is a purity orange appearance, fixed to the underlying muscle, the lump is fixed to the underlying muscle, or palpable subclavicular, supraclavicular lymph node. We will term it as a stage 3B breast cancer. And when there is any kind of metastasis, it will go stage 4 breast cancer. Here is a tricks from where we can easily stage 1 to from TNM scaling. How? Look, when there the summation of T and N is 1, like T1 N0, it will go for stage 1. When the summation of T and N staging is 2, it will go for stage 2A cancer. Okay. And when there is a summation of T and N is stand for 3, it will go stage 2B cancer. But here is exception, which is T1 N2. Summation is 3, but it is not 2B cancer. So remember particularly this, T1 N2 is not 3B cancer. Okay, remaining all of the Tn scaling goes for 3A. When there is a T4, it will be directly 3B. Any N3, there will be 3C, and any metastasis 4. So how will you remember? Summation is 1, so stage 1. Summation is 2, is stage 3. Summation is 3, is stage 2B. Summation is 3, but in case of TNN2, it will not be applicable as stage 2B. It will go for stage 3A, and all other Tn scaling will go for 3A. When the T is 4, become 4, then it will go 3B. N3 go for 3C, and when there is metastasis, go for. Okay, now let's talk about management. We can divide carcinoma of breast into 3 segments. One is early breast cancer, then local advanced breast cancer, and metastasis or advanced breast cancer. Early breast cancer included stage 1, 2A, and 2B carcinoma. In case of early breast cancer, our first choice is surgery. Which surgery? First tell modified radical mastectomy. If teacher asked again, then any other option? Yes, there is breast conservative surgery, and followed by chemotherapy, hormone replacement therapy, and radiotherapy. Our next criteria or type is local advanced breast cancer, which include stage 2, 3A, 3B, and 3C breast cancer. In case of local advanced breast cancer, it includes skin involvement and penetration of beneath muscle, which means pectoralis major or minor muscle. So we need to first compromise or suppress the size of the tumor. So it needs neoadjuvant chemotherapy 3 cycle. Then we can do surgery, which is again modified radical mastectomy, and followed by chemotherapy, hormone replacement therapy, and radiotherapy. In case of metastasis or advanced breast cancer, which include stage 4, our treatment option is palliative care, which include toilet mastectomy and others, chemotherapy and radiotherapy. So let's discuss about modified radical mastectomy. Which structures we should remove in this surgery? Nipple, areola, entire breast tissue, pectoral breast tissue, axillary dissection, which exceeds level 1, 2, and 3 nodes, and which structure should be preserved? Axillary vessels, Bell's nerve, cephalic vein, nerve to latissimus dorsi, and pectoralis major muscle. We can memorize it by A, B, C, D, M. A for axillary vessel, B for Bell's nerve, and C for cephalic vein, D for nerve to latissimus dorsi, and pectoralis major muscle. Pardon here, the E letter will be removed from the spelling. Okay, then in case of modified radical mastectomy, we did incision, we give an incision like this. It is termed as Stuart incision, and from axilla minimum 10 nodes should be removed. Most common complication in modified radical mastectomy: nerve injury, intercostal brachial nerve, Bell's nerve, thoraco-dorsalis nerve, and medial or lateral pectoral nerve can be injured randomly. Lymphedema can occur, and lymphangiosarcoma also occurs. In case of lymphangiosarcoma, it is termed as Stuart-Travis syndrome. Flap necrosis can occur, and seroma is. Breast conservative surgery, it has 4 components, and when you will give 4 components accordingly, it will termed as breast conservative therapy. So our first component is to have a wide local incision around the lump to maintain 1 centimeter free zone from the lump. Suppose this is a lump and it's the margin of the lump, and we have to do our incision 1 centimeter away from the margin of the lump. And in case of early breast cancer, it is done only and when the lump size is restricted in a 1 quadrant. Second component is axilla should be dead. If no palpable lymph node in axilla, then we need to do sentinel biopsy. What does it mean, sentinel biopsy? Sentinel biopsy is the lymph node which is in a direct drainage pathway from the primary tumor. So when you will inject methylene dye into the tumor, the first lymph that will change its color into the blue, it is the sentinel lymph node. So sentinel lymph node is the first node encountered by the tumor cell. Okay, and its histological status predicts distant lymph node basin status with regarding to the metastasis. Means it is metastasis has occurred or not. Because when we will find sentinel lymph node, we will send it to the pathology department, and there it is examined. If there is no carcinoma metastasis, it's okay, and if there is carcinoma or involvement of the tumor cells into the lymph node, sentinel lymph node, we need to do axillary dissection. Okay, then our third component is radiotherapy to the remaining breast. But there is a contraindication. If the lady is pregnant in second or third trimester, we can't do it. We can't give radiotherapy. If the patient have collagen vascular disease or kyphosclerosis or long pendulum breast, because when the radiotherapy plate is placed over the breast, it will affect also the abdomen, because in case of long pendulum breast come forward over the abdomen. Okay, and the most important thing is follow up. When the breast conservative surgery or breast conservative therapy can't give or contraindicated, when the locally advanced breast carcinoma, because it here skin and chest wall is also involved. Only wide local incision is not enough. We need to do total mastectomy. If the multifocal or multicentric breast cancer or BRCA mutation has occurred, or small breast tumor ratio, what does it mean? Like sometimes in some patient, breast size is small in ratio to the tumor. Like a small breast have a huge lump. So on that case, we can't give breast conservative surgery. So now we should discuss about axillary dissection surgery, because it's a very important thing. In axillary dissection, we need the boundaries. First, superiorly there is axillary artery and axillary vein, and which is there is a Holstein ligament, and there is a thoracodorsal pedicle, means thoracodorsal nerve, thoracodorsal artery, and thoracodorsal vein. And another side there is a Bell's nerve, and inferiorly there is a angular vein, and there is a muscle going between them, which is pectoralis minor muscle. So when we retract the pectoralis minor muscle, there is a three level of lymph node, and we need to remove them accordingly. So here is the picture. We have retract the pectoralis major and minor muscle by retractor, and there is a axillary vein, and deep of axillary vein there is axillary artery. This is thoracodorsal vessels and nerve, means thoracodorsal pedicle, and here is a Bell's nerve, and these are the angular vein. So in this space there is level 1, 2, and 3 lymph node is removed. Okay, it's our last slide. We talk something about hormonal therapy. In a case of hormone therapy, the selective estrogen receptor modulator, which is tamoxifen, and other drugs named as anastrozole or letrozole, these are used for hormonal therapy in the breast cancer. In premenopausal patient, only tamoxifen is used, okay, for 5 years. But when there is low risk of patient, premenopausal and low risk, will give tamoxifen for 5 years. But in case of high risk of patient or relapse, we give tamoxifen for the 10 years. So what is tamoxifen? It's a selective estrogen receptor modulator. Here is interesting thing. Tamoxifen is a partial antagonist of estrogen, and it is the selective antagonist to the estrogen only in the breast. So in case of ovarian carcinoma, sometimes when there is a BRCA1 or 2 mutation, there is a chance to develop ovarian cancer also. So in case of that, tamoxifen is not can prevent ovarian cancer, because it is selective to the estrogen only in the breast. It has advantages that it decreases the osteoporosis and blood cholesterol level, which is a risk factor for the breast cancer. And adverse effect of tamoxifen is like bone pain, hot flush, embolic manifestation can occur, hypercalcemia can occur. Okay, then cataract surgery, it increase the risk of cataract surgery. And ovarian cancer, for premenopausal patient, we suggest like gosarelin or another drug which named buserelin. Okay, buserelin or gosarelin, which is act over the ovarian cancer. There is another therapy which is targeted therapy. It's a monoclonal antibody against human epidermal growth factor receptor 2 receptor, which is Transumab. Transumab is a monoclonal antibody, and it is brand name is Herceptin. It is available as Herceptin. There is what is the differential diagnosis of breast cancer? Fibroadenoma, fat necrosis, soft tissue necrosis, phylloids, lymphoma, and if there is inflammation present, it could be granulomatous mastitis. If ulcer present, we can tell about squamous cell carcinoma. But the interesting thing is when you present your history, if there is no relation with ulcer, so don't tell squamous cell carcinoma in DD, because you are memorizing. If there is a small or movable lump, then called fibroadenoma as DD. And if there is a recurrent lump after radiation or surgery, then DD could be phylloids. And if there is an inflammation present or patient have previous TB history, then you could set your DD as granulomatous mastitis, and there is a ulcer over the tumor, then you could tell about squamous cell carcinoma. So you have to understand what you are going to tell about the DD. I would like to draw some attention over the chief complaints. First of all, lump is palpable, so don't write like that. There is a palpable lump for 2 months. No, you should write the patient noticed lump for 2 months, because sometimes lump is small and patient could not feel this. So teachers are getting annoyed that it is not possible to palpable a small lump by the patient. So the patient should notice lump for 2 months ago. It is more appropriate to describe. And then some past history. Past history, breast related question like radiation has occurred or not, radiational exposure has occurred or not, or breast related surgery has done or not. Patient in drug history, we should take about oral contraceptive pill and hormone replacement therapy. And what is the relation about the allergy? Why we should took the history about allergy? Because in the skin problem, there is a Paget disease and eczema. We need to differentiate about them. Paget disease will occur only one breast which is affected by the lump or carcinoma, but eczema is a bilateral. Okay, and there is an allergic history must be present. So thank you. This is all about clinical discussion on carcinoma of breast.